A 79-year-old female with osteoporosis presents with a displaced, severely comminuted olecranon fracture involving the proximal 40%. Which of the following represents the most appropriate treatment? 1. Intramedullary screw. 2. Cruciate wire tension band. 3. Total elbow arthroplasty. 4. Fragment excision and tricep advancement. 5. Hinge elbow brace with early range of movement. And the answer is number 4. Fragment excision and tricep advancement. Excision and tricep advancement, the indication is in elderly patient with osteoporotic bone. Fracture must involve less than 50% of joint surface and non-union. The outcome of this procedure, it is a salvage procedure that leads to reduced extension strength, may result in instability if ligamentous injury is not diagnosed before the operation. In elderly patient, the presence of osteoporosis, metaphyseal comminution, and poor soft tissue conditions, Aubert et al. Showed a complication rate in a patient older than 65 years old after upper reduction and internal fixation ranges from neuropathies, mechanical failure, and wound dehiscence. In mechanical failure, a linear correlation has been reported between the bone mineral density and the holding power of the screw. In the presence of poor bone stock, loss of fixation in the osteoporotic patients remains a problem. For total elbow arthroplasty, TEA, classic indication for elbow arthroplasties is in inflammatory arthroplasties such as in rheumatoid arthritis patient. Other indications include post-traumatic osteoarthritis, acute distal humerus fracture, distal humerus non-union, extreme intrinsic stiffness or ankylosis, large post-traumatic bone defects. Elbow arthroplasty is a very successful in terms of pain relief, motion, and function. However, its complication rate remains higher than arthroplasty of other joints. Common complications include infection, loosening, wear, tricep weakness, and ulnar neuropathy. Lateral malleus fracture can be treated with a variety of techniques including posterior antiglide plating or lateral neutralization plating. What is the advantage of using a lateral neutralization plating instead of posterior antiglide plating? 1. Decrease joint penetration of distal screws. 2. Increase rigidity. 3. Decrease need for delayed hardware removal. 4. Decrease peroneal irritation. 5. Improve distal fixation. And the answer is 4. Decrease peroneal irritation. What is the function of a plate? 1. Compression plate. 2. Neutralization or protection plate. 3. Buttress, antiglide, and blade plate. 4. Tension band plate. 5. Bridging plate. All function of the plate should be applied with respect to preservation of soft tissues. That's why we call it a biological plating. As an introduction, Dennis-Weber type B ankle fracture are the most commonly occurring fracture which are mainly the result of a supination external rotation SER injury characterized by the oblique shape of the fracture line. In displaced fracture, anatomical length and rotational restoration of the distal fibula is required by upon the fracture, leg screw insertion, and plate fixation. This picture illustrates the Weber B SER, supination and external rotation injury. What are the principles of posterior antiglide plating? 1/3 tubular plate which is placed posterolaterally on the fibula in an anti-glide position indirectly reduce the fracture and act as a buttress to resist the posterior and proximal displacement of the distal fragment. Additionally, when the fracture configuration allows, the fracture can be compressed with a lag screw inserted through the plate. The picture depicts the posterior anti-glide plate with a lag screw inserted through the plate. What are the advantages of posterior plating? Among them are non-prominent osteosynthesis material, less loss of fixation, ensures stiffer construct especially in osteoporotic bone, lesser dissection with shorter plates. The commonly used is around 5 to 6 hole plate, easier approach for posterior malleolus fracture fixation. For posterolateral anti-glide plating, a study by Martin Weber et al. 2005 quoted, a posteriorly positioned plate allows use of a thicker, stronger plate and less risk of wound slough. And the distal screw can obtain better purchase since they engage a thicker part of the distal fibula and engage two cortices without the risk of joint penetration. However, the plate can irritate the peroneal tendons and will not allow syndesmotic screw insertion. Okay, this is our answer. For lateral neutralization plating, as a lag screw, osteosynthesis alone is not able to bear weight and sufficiently resist the shearing force. A neutralization plate should be added to allow early mobilization. In the neutralization plate techniques, firstly, the fracture line is compressed with a lag screw, then plate is applied. The fracture line is compressed with a plate and later lag screw in the compression plate technique. As lateral neutralization plating, as a lag screw osteosynthesis alone is not able to bear weight and sufficiently resist the shearing force, a neutralization plate should be added to allow early mobilization. In the neutralization plate technique, firstly, fracture line is compressed with a lag screw, then plate is applied. The fracture line is compressed with a plate and later lag screw in the compression plate technique. The weakness of lateral plating. The screws in the distal fragment often have poor purchase, can loosen and cause loss of fixation due to unicortical insertion. The screws can penetrate to the distal tibiofibula and fibulotalar joint. Wound adhesion is higher in the lateral plate group compared to the anti-glide group. The most common complication encountered in plate fixation cases is symptomatic hardware. Brown et al. Reported that 39 out of 126, that means 31% patients with lateral malleolar fracture internally fixed with plates has a lateral ankle pain related to the side of the plate. Symptomatic hardware was experienced in 66% of cases reviewed by Jacobson et al. Following plate fixation. Plate removal was done for 75% of them. The same findings were present in Tornetta and Gravis series in 56% of the cases. Okay, that's all. Thank you. Isolated exchange rim interlocking nail is most likely indicated as the next step in treatment for which of the following clinical scenarios? 1. Tibial shaft non-union with a 4 cm bone defect. 2. Infected tibial shaft non-union. 3. Hypertrophic tibial shaft non-union with an oblique fracture pattern. Number 4. Atrophic tibial shaft non-union. Number 5. Delayed union of a transverse tibial shaft fracture. 3 months post-op. And the answer is number 3. Hypertrophic tibial shaft non-union with an oblique fracture pattern. The reason for other condition is also stated and highlighted. And again, the reason is there. Allow me to revise regarding a delayed union and non-union. What is delayed union? It is a slowed progression of callus formation and osseous healing in a fracture from 3 to 6 months post-injury. A non-union is a slowed or absent progression of callus formation and osseous healing in a fracture greater than 6 months post-injury. A non-union usually occurs when there is an excess motion, fracture avascularity, fracture gapping, infection, or a combination of these causes are present. The treatment of established non-union include electrostimulation, pulse low-intensity ultrasound, compression plate fixation, augmentive plating that leave the nail in situ after primary nailing, exchange rim nailing, that where the answer is autogenous bone grafting, free fibular transfer, Ilizarov technique. Two of the more common secondary surgical techniques used in the treatment of delayed union and non-union after intramedullary nail failure are dynamization and exchange nailing. Dynamization involves the removal of proximal or distal locking screw in a statically locked intramedullary nail, allowing the weight bearing to stimulate osseous growth at the fracture site. In exchange nailing, it consists of removal of the current intramedullary nail, debridement of the medullary cavity, followed by insertion of a larger intramedullary nail. This procedure utilizes the rimming and increased fracture stability to stimulate osseous growth. The different variation of this procedure has been reported, with varying rates of success attributed to factors such as the use of bone grafting, the size of the medullary rimming, and different nail lock method. So the reason for the number 3 answer is, if a hypertrophic non-union is present, it is most likely a mechanical issue. Hypertrophic non-union has approximately an 85% to 90% incidence of union with exchange rim nailing. A non-union that has bone loss or appears atrophic will usually require improved mechanical stability as well as biological stimulation in the form either autograft or an osteoinductive substance like bone morphogenic protein, or we call it a BMP. A bone defect up to 5 to 6 cm in length can usually achieve union with bone grafting. In the presence of infected non-union, the infection need to be addressed prior to the introduction of any revision hardware. If a patient does not show radiographic signs of tibial fracture union for 9 months and does not have progression towards healing for the 3 consecutive months, then revision surgery should be indicated. Templeman et al. Look at 71 tibial shaft fracture treated with non-locked or dynamically locked intramedullary nail and found the loss of alignment in 11% of the fracture that were not transverse in nature. They concluded that these nailing techniques should not be used in the treatment of spiral or oblique tibial shaft fracture. This explains why hypertrophic tibial shaft non-union occur with an oblique fracture pattern. In an isolated ankle syndesmotic injury, the fibula is unstable in the incisura fibularis of the tibia. In what direction is the fibula most unstable? 1. Anterior posterior, 2. Medial lateral, 3. Proximal distal, 4. Rotational, 5. Equivalent instability of all axes. And the answer is 1. Anterior posterior. Okay? In an ankle syndesmotic injury, the fibula is most unstable in an anterior and posterior direction. This is whether or not there is an accompanying ankle fracture. Most commonly, the fibula will subluxate anterior in an ankle fracture model. What is syndesmotic injury? This term is used to describe a lesion of the ligaments that connect the distal fibula and the tibial notch surrounded on both sides by the anterior and posterior tibial tubercles with or without an associated injury of the deltoid ligaments. It includes 4 major ligaments: AITFL, anterior inferior tibiofibular ligament, IOL or IOM, intraosseous ligament or interosseous membrane, PITFL, posterior inferior tibiofibular ligament, and inferior transverse ligament or TTFL. This illustration depicts the anatomy of the syndesmotic ankle joint. The 4 major ligaments: 1. AITFL, anterior inferior tibiofibular ligament. The function is to limit the fibula external rotation. Number 2, IOL, interosseous ligament or interosseous membrane. The function is to limit the lateral translation of the fibula. Number 3, PITFL, posterior inferior tibiofibular ligament. The function is to prevent the posterior fibular translation. Number 4, inferior transverse ligament. The function is to limit the posterior talar displacement. This picture illustrates the lateral ankle joint ligaments. The deltoid ligament has the function of preventing talar abduction, pronation, and external rotation. Syndesmotic lesion is with associated damage to the deltoid ligament produce a greater instability of the talus. This instability, if uncorrected, can lead to chronic instability that can finally develop into degenerative arthritis. Okay, thank you.